Good afternoon, everyone. This is Jim Brennan from the Massachusetts eHealth Institute. Welcome to our webinar this afternoon. We'll be presenting today with the Massachusetts Department of Public Health on improving population health outcomes by leveraging EHR data and reporting. And my presenter today, my co-presenter, will be Anita Christie. Anita is the Director of Clinical Preventive Services for the Mass Department of Public Health. Anita has an RN and has held a variety of positions in healthcare, including direct patient care, quality improvement, regulatory management, practice management, and public health. In her current position as the Director of Clinical Preventive Services at DPH, she is responsible for oversight and management of all of the cancer programs. She received her RN from Framingham Union Hospital and has a master's in health administration from Simmons College in Boston as well. The Mass eHealth Institute is a division of the Mass Tech Collaborative, which is an economic development organization that was organized in Massachusetts over 30 years ago. There are three divisions within Mass Tech. One is the Innovation Institute, which is doing some work with a collaborative called the Tech Hub Collaborative. It is also doing quite a bit of work in the area of big data right now and also advanced manufacturing. They also publish an annual innovation index about technology and innovation in Massachusetts. One of the other divisions within Mass Tech is the Mass Broadband Institute, which is in the process of a very large-scale project right now to bring broadband access and is constructing out a very large fiber optic network in the central and western parts of Massachusetts around the I-91 and Route 2 corridors, bringing broadband access to all types of businesses out there, including especially healthcare organizations that were lacking broadband internet access up until now. And then the Mass eHealth Institute is our organization, and we specialize in health IT adoption and use. We're the designated state agency for coordinating healthcare innovation and technology in the state. We work to accelerate the adoption of health IT. We are involved in a number of programs right now for health IT adoption and use. We have run the Regional Extension Center program here. We've done a lot of work on the State Health Information Exchange, the Mass Highway, and we have some new programs that we're rolling out that you'll hear more about soon, called Connected Communities, as well as the the various different eHealth services and support that we're going to be providing. So, so our mission basically is to promote health IT in all areas of the Commonwealth. We work with all types of provider organizations to assist them with implementing new technology to improve safety, quality, and population health in the state. So to that aim, I'm going to turn the presentation over now to Anita Christie from the Department of Public Health, and she'll be talking more about how we can leverage the information in your electronic health record systems to improve outcomes.
Thank you for having me today. I want to thank MeHI for helping to support some of the work that we're doing here at the Department of Public Health around chronic disease management. And they have been a great partner for us to help to bring information to you and hope to offer our services at the Department of Public Health for those of you that are thinking of new adoption for an EHR, transitioning to a new EHR, or really trying to identify better ways to use the data that you so prudently put into your EMR to be able to manage your populations within your practice. So today's objectives are to define a little bit about what population health means and a common definition for population health, as well as how we at DPH sort of think about population health. To understand, again, how to use your electronic medical record to implement and report and to help to better manage outcomes for your patients, to provide basic information regarding quality improvement, and to really talk to you again about how we can help you and work together to help do some of the improvement work that many of you will be incentivized to work on. Part of the opportunity that we had in working with MeHI is with the some Centers for Disease Control funding opportunity that is listed here as public health actions to prevent and control diabetes, heart disease, obesity, and other risk factors. And they also have a small component to really think about how we can promote and work with our schools to help promote health within the schools. And within this work, there are 3 domains. The first domain is the environmental health, and that really focuses on nutrition and physical activity, tobacco use and tobacco policy, and really working in the communities to improve some of the environmental factors that impact health. The second domain is health systems interventions, and that's really the basis for this work that we'll be talking about today around helping to manage within health systems and health practices to improve outcomes for patients around chronic disease, particularly for hypertension and diabetes. And the last one is the community and clinical linkages domain, and that really looks at using community health workers or physician extenders to improve the link between services that may be provided in the community and making the clinical linkages with health systems to, again, improve care and access. So as I said, we'll be focusing on the health systems interventions here, and the main activity that really prompted the work that we asked MeHI to help us with was the very first objective, which talks about increasing electronic health record adoption and use of health information technology to improve performance. And that is really sort of the focus of the health systems domain that we talked about earlier, as well as helping folks to think about how to use their technology. Right now we have a pretty high rate of record adoption, electronic medical record adoption in Massachusetts, so we really did want to focus on using the technology and to think about things that you might want to consider when you're doing your selection. As I said earlier, there are folks that have been using EMRs for a while and have some experience in doing that, yet we have very small practices in the state that are considering certain products, and this is really an opportunity to sort of think about what you should look for and your ability to get out of an electronic medical record in order to improve your performance. We've done some work in this area with the community health centers in Massachusetts who have adopted electronic medical records. For the most part, there are still a few folks that have not made a selection, and there are some organizations that are actually transitioning from one EMR to another EMR. And as part of what we had worked on from a community transformation grant perspective, we worked with 8 communities throughout Massachusetts to help with the Mass League of Community Health Centers to help folks look at the data that they were inputting in their system that was transmitted to the Mass League of Community Health Centers and helping to create some feedback reports, particularly focused around hypertension and hypertension management. One of the opportunities I think we have is we've noticed that there have been some undiagnosed hypertensive patients that may have had hypertension for an extended period of time, yet there weren't any sort of medications that were ordered or management of that hypertension to improve the outcome for that patient. So we would see several visits where a hypertension diagnosis could have been made and wasn't made, and therefore missed opportunities to best manage it. So this is just an opportunity to kind of think about those things as we're thinking about adoption as well as reporting. So a little bit about population health and population health management. As you can see from this slide, there are many different ways to sort of think about it, and there are many different groups that you could manage population health. So just a brief definition, and this is one of the most common ones that I came across, and it really sort of describes what we're looking at as the health outcomes of a group of individuals, including the distribution of the outcomes within that group. So when we think about that, there are some subpopulations. Discrete and defined populations are really populations that are receiving care within a health system or a plan that have a specific commonality. The other thing that we look at from a public health perspective is really the regional and community subpopulation, which is a much broader set of patients. So, for example, they use the example here of older adults. And we can look at older adults from a regional perspective or a community perspective, but then you can also have a subgroup within that that is more defined and discrete. For example, an older population that has hypertension or several other comorbidities. So population health management has really sort of evolved over time to think about it as a payment mechanism and really some incentives around managing the population within a practice to improve outcomes. And this is some of the focus around patient-centered medical homes, accountable care organizations, and the Health Policy Commission, which really looks at certification for risk certification for organizations. And it really has begun to focus on the management of those discrete and defined populations. This is sort of talks about and I took this from Mass Tech, which is a great chart to sort of refer to, is really the stage 1, stage 2, and stage 3 of meaningful use. And really stage 1 is having the electronic capacity in place, being able to track some clinical conditions. And as you go through the stages, it's really about managing your high priority conditions, your being able to report out, being able to participate in a health information exchange that's patient-centered. And that's really what we're going to sort of think about today as we're selecting electronic medical records and how we get reporting out of electronic medical records to help us think about meeting all these stages of meaningful use criteria. So how do we measure it? It's not only for insurance providers to be looking at this stuff and giving us information back. It really is that we can have this information available as part of our practices on an ongoing basis to really do some analysis and improvement based on the data that you have. So some of the EMS quality measures are around hypertension management and control, asthma measurement and control, and diabetes measurement and control. And particularly these 3 chronic conditions lend themselves to readmissions that could increase costs, as well as prevent other sort of downward stream implications. So, for example, hypertension management and control, as we know, is very important in the management and control of cardiovascular disease, risk for stroke, risk for heart attack. Asthma management and control has a lot of implications for readmissions to hospital, emergency room visits, and missed days of school, as well as diabetes management that really has some devastating long-term impact for patients who are uncontrolled in terms of macular degeneration, ulcers that don't heal, that require repeated hospitalizations, and things of that nature. So some of the public reporting measures are really around, and these were reported in April 2014, for practices that have 25 or more eligible providers. So these are large practices, and some of the things that they're looking at from the Physician Compare website, and in particular I want to focus on blood pressure control in patients with diabetes. So again, looking at a subpopulation of people that have diabetes but also have blood pressure issues. We know that diabetic patients have a higher risk of heart attacks and heart disease, and management of blood pressure is a reason why this is one of the CMS public reporting measures, as well as hemoglobin A1C control for diabetic patients. So from a quality improvement perspective, I think many folks have known about the Institute of Healthcare Improvement and Dr. Donald Berwick's work in this area in the development of the triple aim. And really the triple aim is looking at improving the patient experience, which includes quality and satisfaction, improving health of populations, and really reducing costs. And there is an assessment tool on the IHI website that really helps organizations to sort of think about this in a way that they can position themselves and I would recommend that folks sort of visit the website and take a look at that assessment tool. It really helps to have you better understand what you need to be ready what you need to have ready in order to meet the triple aim framework. The Institute of Medicine defines quality as the degree to which health services for individuals and populations increase the likelihood of health outcomes, desired health outcomes, and is consistent with current professional knowledge. And this is very important because there are a lot of clinical practice guidelines that can be worked into an EMR to help you manage patient outcomes, and those are based on the most recent clinical knowledge. So I could use the example of cancer screening guidelines, and an EMR can be designed and can be worked through an algorithm that will help you identify those patients from a population management perspective who are in need of screening or who have not had their screenings for extended period of time. Similarly, we can talk about patients who have not had an A1C done for a year when they should be having it done at least twice a year. Those kinds of examples. There are also some standards of care that are based in the community that an EHR can help you sort of manage that this is the best practice for your community, and assuring that there are some key prompts for providers to follow in order to make sure that you're meeting those standards. So some tools in your EMR and some things to think about when you're thinking about quality improvement from the perspective of using your EHR to identify populations and missed opportunities. Reports, as I said, can be sort of defined within an EMR, and it's really helpful to think about those things as you are considering initiating an EMR or changing to a different EMR. That would really help you look at information over time. Again, as I spoke about missed opportunities or identifying specific patient populations. And some of the quality improvement techniques that you can use based on those reports is really thinking about how you can do a process redesign within your organization to better meet the needs of those patients. There's also many tools that can be used to look at trends, for example, pies or scatters or bar charts that help you really transform the data that you're collecting information that's usable. And then on your right-hand side of the screen, there is the model for rapid cycle improvement. That is the Plan, Do, Study, Act cycle. And that cycle really helps you to identify what you want to accomplish, creating an aim, and then really working around process redesign and small cycles of change to demonstrate improvement. So reporting can be designed in any number of ways, and it can be run as you need it to be run. It can be run daily to manage a population as part of a process. It could be run quarterly to look at trends, and it can really help you monitor the impact of whatever improvement you're putting forward for your practice. And some of the stratifications that are often helpful are age, race and ethnicity, because we know that there are certain populations that have higher incidence or higher risk factors. So for example, the African American population with high rates of hypertension that often go undiagnosed and untreated. Any comorbidities, we spoke earlier about diabetes and the impact on cardiovascular disease, so that's an important one. And then any diagnoses that are specific and things that you feel that you would need to work on. Asthma might be one of them. If you have a high rate of asthma within your adult population, that's a key piece. In your pediatric population, most definitely. And trying to create some workflows that help you identify and better manage those patients within your practice. One thing that this will require, and part of one of the other important things to think about, is family and personal history and maintaining problem lists, because those can often be used as identifying new diagnoses for a patient, identifying a change in family history that could then put a patient at higher risk. I'll use prostate cancer as an example, where you have African American men who are more likely to die of prostate cancer, and also people who have a family history of prostate cancer also puts them at a higher risk. A couple of other things that could also, add to this in terms of comorbidities and chronic disease is anyone who has a cancer diagnosis often would have more difficulty in managing a chronic disease like hypertension. Anyone who has a diagnosis of depression or mental illness or mental health issues, because often those folks also have additional challenges in managing any chronic disease. And certainly tobacco use, that puts people at a higher risk for a whole host of chronic illness. And one of the other important things here to think about is when you're creating reporting, you want to be able to look at discrete elements of data. So, for example, being able to run a report based on the last blood pressure, for example, or based on the last A1C. Those are really important measures for hypertension and diabetes that as you start to begin to create reports, you're able to look at trending over time. So I just wanted to give you a brief example, and again, this is only one example that has also been presented in the past as part of a webinar that Reliant Health Group had done. They're part of a very large network and accountable care organization called Atrius Health. They are based in Worcester, and they serve primarily central Massachusetts. There are many vendors that people can select as part of their EHR process, and this is just one example of how Radiant Health has used their EMR to help them manage their diabetic population. And it's important to think about this as you're starting to make your selections or really thinking about what information do I need to help better manage my population. The main objective for Reliant was to think about how to improve their diabetes screening and management. And so they developed a process that looked at things that can be done prior to folks coming in for their comprehensive physicals, what the providers do during the visits, and what orders are then promulgated during that visit to help manage, as well as a post-visit follow-up by the MAs. And the EMR that they use here is EPIC, which they had developed some embedded clinical guidelines that I talked about earlier. They developed some clinical decision support for the providers and really did change their process and workflow redesign within the practice in order to help to manage their patients. So prior to a routine physical, the EHR guidelines automatically suggested testing, and again, this is sort of that stratification of patients within the practice according to age, their gender, diagnoses, smoking history, medications, and existing orders and results that hadn't been addressed yet. And the staff would draft the orders for the physician to sign. So here's a screen where they can just sort of click off what orders they felt that that patient needed to have done, and that would automatically go to the physician. So the nurses would automatically receive, prior to the visit, for all their high-risk diabetics, a message prior to that would allow them to review the records, look at their histories, do some education, and check any labs, and then have a conversation with the patient, either at the time of the visit or prior to the visit. And at the time of the visit, labs would be identified that should be scheduled, that were overdue, and then the physician, right from that screen, as the patient is in the room, would be able to order these because it's identifying that this patient is overdue for their hemoglobin A1C, and the test had already been ordered. But and again, this is interesting because the way that they had looked at this was to remind them to go to the lab. And this is also looking at the next order in sequence that the physician can order during the time of the visit. And in this particular case, it's the diabetic eye exam. And again, what's dynamic and pretty robust about EPIC is that it doesn't ask you for an order if it's not due or if it's already been ordered, which is really nice. So again, this is the clinical decision support that's sort of built into this particular particular interreliance work. So then the MAs call in between patient visits, and they have a category called BAD, which is really sort of things that needed to be actionable. I'm not quite familiar with how they sort of came up with this criteria, but it really does help to identify people. Again, you're seeing the patient medical record number, you're seeing their name, you're seeing the date of their last A1C. So what it does here is that the higher the number, the more actionable this would be. And MAs take action on these on an individual patient basis. And what they've seen, as you can see from this slide, this is again an example of trends over time and being able to get this information from your EHR that allows you to look at your screening rates over time. And this is a really good example of how just that they had a lot of variability in their practice, that they did have a slight drop as their EHR went live, and that's something to sort of think about as you're implementing change and as you're starting to look at data. Change and transitioning from a paper record to an EHR is very challenging, as is change from one EHR to another EHR. And oftentimes you do see a little dip, but then as they've started to put the decision support in place, it was a rapid rise that continues to increase. And right now they've gone from a 94% to a 98%, which is above the 90th national percentile. Similarly, with their patients who are in control for their diabetes, again, with the follow-up for abnormal findings from the MAs, follow-up from the nurses, they've been able to demonstrate a really nice curve that's on the upward trend, and again, above the national 90th percentile. So the implications for this is as you begin to think about paper performance and being able to manage within your practice a specific population of patients, being able to think about your role as part of an ACO potentially, that reimbursement kind of will follow these trends. As you get better, your reimbursement to your practice will also improve. So one of the key things to think about, and this is really what we all need to think about as we start to implement any sort of improvement process, is really to have strong leadership that is going to take the charge, that is going to be the champion for you as you try and do what can be some very painful things. Changing process is a dynamic and involves multi-layers of the institution or the organization that you work in, and it's really best implemented if you get input from the folks who will really have to do the work every day. So I think that you need to have strong leadership that will identify that as a priority and will know that this is an important initiative within your organization. So that is critical. EMR reporting capability is another important thing to think about. As we saw, you should be able to have data when you need it, be able to measure what you want to be measured, and be able to have strong supports and teams in place to implement any change and take a meaningful action. So how DPH can help. As I said in the beginning, we have a grant that we are working on to really help folks to use their EMRs in a meaningful way to help them improve population health. We have some resources here at the department that if people are interested in working with us on this, we could offer you some data assessment. We can talk to you about developing aims and quality improvement techniques and team development, and really help to assist people to look at their workflow and their work processes to help improve population health outcomes. And we are, able to offer some individual technical assistance as resources allow us to do that. to really demonstrate an effective process to help to work with all of you, whether it's at the initial stages of thinking about implementation and vendor selection to really looking at process redesign and quality improvement.
Thank you, Anita, and thanks for all of that good information on the presentation there. We just a little bit of a recap on MeHI and some of the things that we're doing. Anita just mentioned some of the assistance that DPH can provide. So we do provide meaningful use services and support. MeHI is the operational group for the Medicaid EHR incentive program. So if any of you have providers that are enrolled and applying for meaningful use incentive payments through that program, the group that evaluates those applications and approves them and so forth is part of the MeHI organization here. We also have the Regional Extension Center, which is funded by the Office of the National Coordinator. We have federal funds for consulting assistance for providers that are still working on stage 1 of meaningful use. So if you have providers that are not yet attested for the first year, the first stage of meaningful use, we can fund some consulting assistance for those providers. And then we're going to expand on the Regional Extension Center program and provide some additional services for future stages of meaningful use and beyond stage 1. And those services will be rolled out in the fall of this year. And some of those will include preparation for incentive payment audits. We're adding a PQRS registry to our services, and there'll be a member portal where you can store documents and submit your PQRS information and keep track of where you're at with meaningful use. And there'll be some other tools available on that portal for providers. So all those things are coming up in the next couple of months, so check back in with us if any of that is of interest to you all.